Good afternoon, everybody, and thank you for joining us for the October Choosing Wisely Learning Network webinar. This month, we will be discussing effective messaging to the public. But before we begin, let me cover a few logistics. This meeting will be recorded and shared. While our presenters are speaking, we will have the lines muted to reduce unnecessary noise. However, we will unmute the lines at the end of the presentation for questions and comments. And I do encourage you to use the chat box while the speakers are speaking to ask any questions or comment also through the chat box. Today we welcome two speakers. Our first speaker is Susie Dade. Ms. Dade has worked in healthcare in Washington State for 37 years. Currently, as Deputy Director of the Washington Health Alliance, Ms. Dade is involved in virtually all aspects of the Alliance's work, but has a particular focus on strategic planning, performance measurement, and reporting, purchaser engagement and value-based purchasing, and provider performance improvement. From 1980 to 2005, Ms. Dade held several delivery system leadership and planning positions, including 16 years with Group Health Cooperative. Welcome, Susie.
Great. Thank you very much. Well, good afternoon, everyone, and thanks for having me today. So today I'm here to talk about waste in healthcare and a new tool that we're using to identify waste in Washington State. But before I kind of dive into the results, I just want to take a minute and talk about why we care about this topic here in Washington. Next slide. So let me start with 5 numbers. So 5.5%, this is the average amount that national health spending is projected to increase every year through 2026, a number that is more than twice wage growth, 1 percentage point more than GDP growth overall, and more than 2.5 times the Consumer Price Index. $5.7 trillion is what we're projected to spend on health care in the U.S. by 2026, and this will be close to 1/5 of the gross national product. Almost 1/2 of this cost, 47%, will be borne by federal, state, and local governments, creating huge opportunity costs for things like education and transportation, criminal justice, defense, innovation, and more. And nationally, we've all heard these estimates. Experts align around a number showing that the amount of waste in healthcare is somewhere around 25 to 30%. But you know, even if this is high, say it's only 20%, the cost is incredibly high at $1 trillion. Next slide. But more important than this, with waste in healthcare, we are harming people every day. We are harming people every day. Next slide. So, you know, I think in healthcare we've grown accustomed to working to avoid physical harm like infections or medication errors. These types of things are really, truly awful whenever they happen, but they are particularly tragic when they happen in conjunction with a medical treatment that wasn't needed in the first place. And maybe we think about avoiding emotional harm, alleviating anxiety and worry for patients, both of which can be crippling under certain circumstances. Here, think about false positives from a test that wasn't recommended in the first place, that then leads to all kinds of unnecessary care. But then also, what about financial harm? Today, the high cost of health care and high deductible plans represent a real and growing risk to people. Deductibles can range from $500 to $6,000 per year for a single individual. Nearly 1/2 of Americans say they'd have difficulty paying an unexpected $500 medical bill, and it's estimated that close to 1/2 of Americans have less than $1,000 in their savings accounts. Medical debt is the single largest contributor to personal bankruptcy in our country, and yet we just keep doing things to people in healthcare that are unnecessary and then sending them the bill. Financial harm is harm, and it's just way past time that we started thinking about it this way in healthcare. Next slide. So with this as context, I want to share the results from a report released by my organization earlier this year. It's called First Do No Harm, and it is a report about waste in healthcare. You know, I'm often asked, why did we pick this title? Well, it's because First Do No Harm is a fundamental rule for bioethics taught in medical school. Basically, it means that it may be better to do nothing at all than to do something that presents a risk of harm to the patient that is greater than a chance of benefit. And I would say we've traveled some distance from this fundamental rule, and it's really time that we get back to it in American medicine. Next slide. My organization, the Washington Health Alliance, manages an all-payer claims database for Washington. And we used a new tool called the Health Waste Calculator developed by Milliman MedInsight. The calculator uses software to analyze insurance data, which we have, to identify and quantify wasteful services. We used a version of the calculator called version 5 that for this report, for these results. It includes 47 measures, and all of them tie to specific Choosing Wisely recommendations. And this was really important because we knew we were starting by looking at things that are known by the medical profession to be overused and potentially harmful. The calculator looks at both facility and professional claims, and it uses situational intelligence that defines each service with a degree of appropriateness. It puts it into one of 3 buckets: necessary, likely wasteful, and wasteful. And we ran a portion of our all-payer claims database through the calculator, including data on 2.4 million commercially insured people. This is about 1/3 of Washington residents. Next slide, please. So the word waste makes some bristle in healthcare. We know. In fact, many in the Choosing Wisely campaign don't like that word, and they prefer a term like low-value healthcare. But frankly, the word waste resonates for employers, at least in our state, for employers, insurers, and even some provider organizations, and they actually want us to call it out. They say use the word. It is wasteful. But regardless of what you call it, here's what we're talking about. We're talking about doing thousands of medical tests, treatments, and procedures that have been shown to provide little or no benefit to patients and have the very real potential to cause harm to people. So before I get into the results, I just want you to bear 3 things in mind. The first is that the calculator includes 47 measures. So we're really only looking at a small subset of the total potential areas of healthcare waste in our state. And with results for 2.4 million people, while that's a very large representative sample, it is not a comprehensive analysis of everybody living in Washington. And the estimated costs are only associated with the particular service in question. In other words, the costs that I'm going to show you don't include any follow-up tests or treatments or complications that may have occurred as a result of the initial unnecessary intervention. So that's something we would call the cascading harm. And interestingly, the Milliman MedInsight team is working on a measure of iatrogenic or cascading harm so that future versions of the health waste calculator will be able to give us some idea of what that kind of rolling wasteful services looks like and how it's impacting us. So here we go. If you could change the slide, Kelly. Across the 47 measures, we looked at 1.5 million services in 1 year. Of these, about 46% were determined to be low value, meaning a combination of likely wasteful and wasteful. But you can see that the likely wasteful category there, that tiny sliver, 1.3%, is a very small amount of the overall wasteful services. Next slide. About 1.3 million individuals in our state received one of these 47 services, and among these people, almost half of them, about 622,000 people, were impacted by waste. Next slide. An estimated $785 million was spent on these 47 services, and approximately $282 million, or a little more than a third, was spent on waste in 1 year for 47 things. Next slide. Results for each of the 47 measures vary across different counties in our state, which we find interesting. You can find this level of detail on our community checkup website, and the website is listed there on the slide. In this particular example, we're looking at annual cardiac screening for low-risk patients. From our data, we know that unnecessary cardiac screening rates can vary by 15 percentage points across different areas of our state. And so that's interesting, and it's part of the conversation we're having about geographic variation. Next slide. So we took a closer look across the results for 47 measures, and we found that just 11 account for 93% of the waste measured. These same 11 measures accounted for 89% of the estimated spend associated with waste. So this is a really perfect example of how data can help us to quantify the problem and know where to focus interventions, because if you've got 11 out of 47 areas that really are 93% of the waste, it means that you really don't have to spend that much time focusing on some of the other like 36 things on the list. So next slide. Here are the things that we can focus on in Washington. Preoperative lab studies and other tests before low-risk procedures for people who are otherwise healthy. We spent $92 million in 1 year, and 100,000 people were impacted. Annual cardiac screening, I just mentioned, 73 million, 102,000 people impacted. Unnecessary or too frequent screening for things like cervical cancer, prostate cancer, and vitamin D deficiency, $41 million and over 200,000 people impacted. Unnecessary imaging for eye disease, low back pain, or simple headache, $45 million and 96,000 people impacted. Altogether, these things add up to impacting over 577,000 people in my state, with a price tag of over $250 million in just a 1-year period. Next slide. So what's the utility of this work? We know that it's not enough to just produce data and stick it on a website. Next slide. Yes, the data is very important. I mean, it's really foundational. It needs to be robust and from a trusted source. The data must be transparent and presented in a way that clearly quantifies the problem and differentiates performance. The data is essential, but by itself, it is not sufficient to create change. Next slide. We also have to translate the data into useful and actionable information for a mixed audience. Not everybody is a data wonk, and sometimes I think those of us who work in this profession kind of forget that. And every day I encounter really, really smart people who are in decision-making roles who actually need help understanding this work and what to do about it. And for them, we need to really create a compelling story and support different learning avenues. Next slide. Conversation among different stakeholders to really urge honest dialogue, and here I would underscore the word honest. A dialogue, engagement, and understanding, all of that is essential. And ideally, it's really facilitated by a neutral and objective third party, because these are difficult conversations. I mean, we've been talking about quality in healthcare for some time now, and of course, improving quality, like improving underuse of effective care. Much, much easier conversation to have than a conversation about reducing waste. But the conversation is foundational to building a new culture and breaking down barriers, both seen and unseen. And then next slide. And then so as you're working on translating and conversation and understanding, you can finally get to a point where you can begin to look at action. Here I'm really talking about focused activity that rewards behavior change and aligns incentives with higher value in healthcare. And there are multiple levers, and all of them need to be deployed. Next slide. Here's a list of strategies that we think about in Washington to reshape supply and demand, demand being patient-facing and supply being provider-facing. All of it with the ultimate goal of reducing waste in healthcare. The list is really long, and I don't think I have time to talk about each of them in detail, but I will note that all of them require data translated into information that informs decision-making, either by patients or by providers. Next slide. In Washington, we have a number of initiatives underway to use results from the Health Waste Calculator. We have a statewide Choosing Wisely task force that's focused on working with clinician leaders to disseminate results and implement effective strategies for reducing waste. This is a group that's been ongoing for a number of years now, and it's a wonderful group of pretty enlightened, progressive clinician leaders who understand the need to reduce waste as an important component of quality. Next, we're actually finalizing a new report with refreshed results from the Health Waste Calculator that's supposed to come out next month in November. We're using the latest version of the calculator, which is actually called version 7, and it includes 48 measures. Some measures have been deleted, some have been modified, and there's some new measures this time around. And there's some interesting new areas of focus, like prescribing opiates for acute low back pain within the first 4 weeks. Obviously a really hot topic. And this time our report will include results for both the commercial and the Medicaid insured population in our state, including results for a total of over 4 million insured lives. We're also working with large purchasers in our state, in particular the Washington Healthcare Authority and the Boeing Company, to produce purchaser-specific results for them. Together, these two actually insure more than a third of the residents of our state. So, helping them to really zero in on their specific populations will help us develop, specific targeted strategies. And then finally, we're working with the provider community, really through our Choosing Wisely task force, to develop specific interventions based on the results. Next slide, please. The first area that we picked to work on is the one related to unnecessary pre-op testing before low-risk procedures. If you remember, I mentioned a minute ago that it impacted about 100,000 people and cost over $92 million in our state during a one-year period. We worked together with a group over the summer, and we developed an information flyer that will be part of a statewide communication campaign called Drop the Pre-op. We're collaborating with our state medical and hospital associations on the campaign, and we're just actually getting started on it. Next slide. So despite having all of this great information to work with, we know that there are significant barriers to engagement, and I was asked to talk about what I think some of those are that we've encountered in our state. So I'm going to touch on a few of these. Next slide. A really big one, of course, is fee-for-service payment, still the predominant form of provider payment despite advances on value-based payment. It's pretty simple. When you're paid more to do more, you do more, whether it's necessary or not. And in this financial environment, it's really hard to build in safeguards to ensure clinical appropriateness and an avoidance of wasteful care. Next slide. You always have to be mindful of our culture of more. We think more interventions are better, more scans are better, more surgeries better, more pills are better. In this country in healthcare, we have this massive cultural blind spot that says if I'm getting more and it's costing more, then it must be better. But with our data, we know that price doesn't correlate with quality and quantity doesn't correlate with quality. This is how transparency is helping us to separate fact from myth. But the culture of more is really strong, it's pervasive, and it's extremely challenging to change it, particularly when the financial incentives are misaligned. Next slide. A third barrier to engagement is that the delivery system is just totally swamped with requirements and priorities. I'm sure you hear this in your communities. The list of to-dos for the provider community is pretty darn long, and there's only so much bandwidth for QI initiatives. And, make no mistake, reducing waste is improving quality and reducing harm. And that's what we need. That's how we need to frame this and move forward. And we need to make sure we're doing the right thing, the easy thing, with supportive infrastructure and tools at the point of care, so that providers are supported in making the right decision with the patient. And then finally, there's the ever-present, next slide please. Finally, there's the ever-present barrier of a lack of resources to do this work. Accessing data is expensive. Resources to support measurement and analysis are hard to come by. resources to create educational materials for a variety of audiences on a variety of topics, and then resources to reach target audiences. These are things, that we struggle with. Finding waste takes resources, and addressing it takes resources. So that's clearly a barrier that we encounter. Next slide, please. So although I've outlined some of the bigger barriers to engagement on this topic, I would just conclude by saying that despite all of that, we just have to keep trying to find a door through the wall. We can't sustain the spending trend, and we can't continue to harm people with wasteful care, whether it's physically, emotionally, or financially. We just simply can't do those things. Next slide. So while we're just getting started, we know that we're doing way too much unnecessary stuff to patients and that we're harming people. And our early results are just really the tip of the iceberg, but we're pretty excited about this work. I'm traveling around the country talking about it a lot and trying to get other people excited about it. And we really look forward to continuing to dig and tell this story, hopefully to affect change. And with that, I will conclude.
Thanks so much, Susie. Before we turn it over to Neil, one of the things I was struck about the report was how much media coverage that you received about it.
Yes.
Do you think, what do you think helped you get so much coverage? And has the media coverage, have you seen a sizable help with that? Is that education moving anything along?
Well, it's true. We got more coverage for this report than any report we've done in the last 10 years. And for me, that was really encouraging because it means that at least some in the media and in the public are really ready to begin having this conversation. I mean, in your introduction, you talked about me working in healthcare for, it's actually now 38 years, and it makes me feel old when I hear people say that, but I can't even imagine having a conversation even about transparency 20 years ago, let alone really just talking about waste and using that word waste and having people engage in the conversation. So we have a long way to go on this topic, but the fact that it did get so much media attention was really encouraging to me. I think one of the things that, one of the pieces of advice that we got that was excellent advice, and we continue to follow it, is really frame this issue as an issue of harm. And the money issue is secondary. So for example, when I get results from the Health Waste Calculator, and I'm ranking them, like what are the top 10 areas that that appear to be the most wasteful. That ranking is always done by the number of people harmed or the number of wasteful services delivered. And the money, like, oh, and this costs $250 million, that's secondary. So the money is not the driver of the conversation. Harm, that's why we called it First Do No Harm. Harm is the driver of the conversation, and then the money helps to give a sense of the magnitude of the problem.
Great. I think that's a great point, that harm does seem to be both a motivator for patients and providers.
Exactly.
Thank you. I am going to open it up to discussion after we hear from Neil. But if people would like to put questions for Susie while they're thinking of them in the chat box, you're also welcome to do that. Thanks so much, Susie. Our next speaker is Neil Goldfarb. Neil is the chair of the Board of Governors for the National Alliance of Healthcare Purchasers Coalition. Additionally, Mr. Goldfarb is president and CEO of the Greater Philadelphia Business Coalition on Health. He brings over 30 years of healthcare research and management experience to his coalition leadership position, including his roles as Associate Dean for Research in the Jefferson School of Population Health and as Vice President of Health Services for the Philadelphia region's first Medicaid managed care plan. Welcome, Neil.
Hi, thanks, Kelly. And Susie Dade is definitely a hard act to follow, although I will say I have a couple of years up on her regarding number of years in healthcare. So I'm going to be talking about our efforts at the national level working through regional coalitions to try to drive employer and employee awareness of the need to reduce, whether you call it waste or harm or overuse. We all recognize there's a problem here. Next slide. So just to remind you all, employers have skin in this game. Employers cover roughly half of the U.S. population in terms of where people get their health insurance and where the dollars are coming from. And so employers really have a vested interest when we talk about overuse or waste, have a vested interest in trying to do something about that. Next slide. So I mentioned, and in the introduction Kelly mentioned, I am the president of a regional business coalition on health. So we are based in the Philadelphia area. We cover Delaware, a little bit of southern New Jersey, and the southeast corner of Pennsylvania, 4 counties that surround Philadelphia County. Our mission as a business coalition is similar to the mission of our brother and sister coalitions around the country, which is to really help employers keep employees healthy, but also to represent the interests of employers in trying to improve quality, safety, and value for the healthcare system. Next slide. So we're part of this national alliance of healthcare purchaser coalitions. The Washington Health Alliance, which Susie just spoke about, also participates in the national alliance. We have around 50 members around the country. These coalitions usually are defined geographically. They represent over 12,000 individual employers. Many, but not all of those employers are self-funded larger employers. We represent over 45 million covered lives across the country. So, you know, a significant opportunity for regional business coalitions on health to drive change in their local markets. The National Alliance provides a forum for us to exchange information, to learn from each other, to develop initiatives at a national level that multiple coalitions can implement, and one of those that's currently being worked on is this Choosing Wisely awareness campaign. Just at the bottom of the slide, I did want to point out while we're here that the National Alliance has its annual conference coming up around a month from now in Washington, D.C., and if you're interested in interacting more or learning more about employers and coalitions, a great opportunity for you is just a month away. Next slide. So we started talking with the ABIM Foundation staff several months ago when we learned that Consumer Reports was going to be stepping back from the role it had originally played of trying to educate consumers. And so Mike Thompson, the CEO of the National Alliance, and I approached Daniel Wolfson and said, let's get a dialogue going about how the National Alliance can support the objectives of educating and engaging both employers and employees as consumers. We were fortunate in that Daniel offered us a ABIM Foundation seed grant to get our activities moving. And so these were the goals of that seed grant, really to try to educate employers and coalitions on the Choosing Wisely campaign, let them know what it is, heighten awareness about what it's trying to accomplish, why they have skin in the game, and what they can actually do about it. In order to move this project forward, we've convened a consumer purchaser advisory committee that is both helping us and also giving some feedback to the ABIM Foundation on employers' interests and what we can do to craft the messages to better engage employers and employees. The seed grant also included our selecting one topic for a National Alliance action brief. So action briefs are issued periodically by the National Alliance on topics that we think are going to be relevant and interesting to coalitions and their employer members, and that always lead to action. So it's not just about education, it's really about here's a problem, here are some tools, here's what you can do to implement action to start to address this problem. And so we committed to creating an action brief around the Choosing Wisely campaign. And then we'll continue to talk about how can we sustain our efforts and support local coalitions as well as the National Alliance in really building momentum. And so that, of course, usually implies getting some external funding. Next slide. So I mentioned that we convened a Consumer Purchaser Advisory Committee. Just to point out, there are a good number of coalitions. We originally, I think, said that we would have 6 to 8 coalitions participate in this group, but the interest was so strong across our member coalitions that we ended up with around 12 participating coalitions. We also thought it would be important to get the viewpoints of employers, and so a few of the coalitions helped us to identify employer members who seem to be interested in this topic. Our committee meetings also are attended by the ABIM Foundation staff and also by the National Alliance staff. Next slide. So what we decided to focus on for the initial action brief, which we hope will be coming out within the next month, is sort of multifold purpose. The first was just to talk to people about why should they care about overutilization or waste. Let them know what the Choosing Wisely campaign is, because some of our member coalitions and some of their members still don't know the Choosing Wisely brand. Many of you have probably seen the 5 questions card that was developed to stimulate meaningful conversations between consumers and providers about, is this test really necessary? What are the alternatives? What's it going to cost me? And so really trying to empower consumers to say, it's okay to talk to your doctor and ask some questions. And so we want to make sure that the employers are aware and translate to their employees that these resources exist. We're going to focus on overuse of imaging tests in this initial action brief. There were a few reasons why we did that. We had some discussion in this advisory group committee. As you saw in the Washington Health Alliance report, 3 of the 11 top offenders were imaging tests. And so we thought volume is there, money is there, and as Susie has pointed out multiple times, harm is there. Overexposure to radiation, we know, is a bad thing, definitely for pediatric populations, but also for adults. So in the action brief, we'll talk about specifically what do we know about overuse of imaging services, what does Choosing Wisely specifically have to say, what are those specific items in the Choosing Wisely list that relate to overuse of imaging, and we're choosing those 3 things that came up on the Washington Health Alliance list and that have come up on other lists when other groups have run the Milliman waste calculator. CT for headache, imaging tests of the eye, and use of imaging for low back pain in the first 6 weeks of a patient presenting with low back pain. And probably most important, as I said, is this is an action brief. So what can employers actually do about this? And so the next and last slide will really talk about what are we recommending to employers and trying to do to get them to engage their employer, to get the coalitions to engage their employers, and to get the employers to engage their employees. So the first thing is we just want to heighten awareness. We think at this point any business coalition on health should absolutely be aware of, if not committed to, the Choosing Wisely campaign. We're the purchasers. We need to drive change in our local markets. And so become familiar with Choosing Wisely, what it is, what resources are already available, and what can be tapped into to start to drive change at the local level. We're encouraging employers to share this information with employees. and consider distributing the 5 questions card as a good starting point to get consumer engagement. We're thinking about how we might develop actual specific advisories, some of which already exist, some of which are legacy tools from the Consumer Reports years, and make these tools available to employees. So let's keep the Choosing Wisely name out there in front of employees via intranets, via racks of information at whether it's in the cafeteria or in the HR office. Let's really think about how can we disseminate and sustain that brand visibility. We're also, specifically to imaging tests, encouraging employers to start to look at their own data. So as Susie mentioned, in Washington, Boeing would like to see its own data, and I know that this is true for almost every employer. They understand, yes, there's a national issue. They understand maybe there's a statewide issue. They always get most engaged when they see their own data. So we want to encourage employers, whether they tap into the Milliman calculator or for many of these, when we pick out individual tests, they can use a couple of CPT codes, look at their data, see how many of these things they're doing and what it's costing them, just to ballpark it. So look at your data. Talk to your benefits consultant, and I think this is another point. Very few employers do things totally on their own. Almost every employer is reliant on benefits consultants, so a key strategy is for us to get the benefits consultants equally engaged and aware, and to really have them driving some of this data analysis for their clients. Similarly, we want the health plans and third-party administrators to recognize that they need to be working with the Choosing Wisely toolkit. So we want employers to look at what they're doing, what they're spending, and where are the opportunities to make change, whether that's through steering care, through changing the benefit design, through provider education and incentives. We want, as a starting point, for employers to recognize that there's a problem and that they have the power to do something about this. And so finally, we want this to lead to action where the employers are the change agents who go out to the health plans, who go out to their major provider systems, talk to their benefits consultants, go out to their vendors, like their disease management vendors, their diabetes management programs, et cetera, and ask them all, what are you doing to address this overuse problem? How are you incorporating Choosing Wisely into your criteria sets? How are you identifying providers who are doing a better job in being stewards of appropriate use of services? We encourage, we're not at this point yet, but we want employers to start to think about value-based insurance design strategies, which basically means change the benefit design so that co-pays are higher for low-value services if you cover those low-value services at all. And the obverse of that is for high-value services, why are you creating financial barriers through co-pays and co-insurance? We want employers to think a little bit more about if they're not already doing prior authorization, should they be doing prior authorization for some of these imaging tests? And also to think about who's doing those reviews, is it being conducted appropriately, and again, engaging with their health plans and other vendors to make sure that where there is prior authorization, it is working properly. And then finally, employers have an opportunity, particularly working with benefits consultants or health plans, to start to identify providers, maybe initially at the system or group level, where those providers are using imaging tests at high rates. And think about engaging in a dialogue about, is this a risk issue? Is this a severity of illness and bias selection issue? Or is it a overuse? Is it defensive medicine? And what can we do together to reduce utilization? So for me, it's really exciting to hear Susie talk about how some of the key provider organizations have bought in to the Washington Health Alliance campaign. We have to recognize this is a multi-stakeholder problem, and it's got to be a multi-stakeholder solution. So that concludes my introduction.
Thanks so much. And before I open it up to everybody, I'm going to take the opportunity to ask a question. And you both talked about multi-stakeholder. What do you think how do you think employers are particularly positioned to lead these conversations with patients, particularly when we're talking about, as Susie said, honest and transparent information? How do you think employers can help health plans and also providers who may be overwhelmed with things to do lead these conversations?
Yeah, I think that's a great question. You know, employers oftentimes can be the catalyst, but don't necessarily have the time to do all the heavy lifting with the other stakeholders. They can bring them to the table, they can tell them what their expectations are, and remind them that ultimately they're footing the bill. So I think there are a few things employers can do here. One is absolutely, given that employers cover health benefits for half the country, employers can be a major dissemination arm for the Choosing Wisely campaign and just heightening awareness. In terms of those other stakeholders, it's really, I think the employer has the economic power to get those stakeholders to the table and to get them talking and to get them to develop the action plan. Now, that's not to say the employers won't be engaged, but I think the employers play a more critical role as a catalyst. The other thing I just want to point out is many employers, rightly or wrongly, have implemented consumer-directed and high-deductible health plans, wanting to give consumers more skin in the game to make appropriate choices of are things necessary. We think I'm not a big proponent of CDHPs and HDHPs, but I absolutely insist if you're going to do it, you need to educate consumers and give them the tools. And I think Choosing Wisely is a fundamental part of that toolkit to say, here are things that even the providers agree are wasteful.
Yeah, so I would just add a couple comments. So I think purchasers in particular are really a vital part of this equation. And the reason I say that is because purchasers are a vital part of the equation. And the reason why is because both providers and payers actually make money on waste. And so they have some self-interest that's pretty difficult to overcome without an external force as an influence in the discussion. The second thing I would say is that I, too, am not a huge fan of big, high-deductible health plan design. And the reason why is because we know that health literacy in this country is very low. I mean, there are estimates that somewhere around 77 million adults in this country actually have difficulty following pretty basic health instructions like the instructions on a prescription label. And so then we just, we hit them with this high deductible health plan design, and we expect them to exercise consumeristic sort of behavior, but they don't have the tools or the information to do that. And so what happens is that they are the ones that end up being really financially harmed. I don't think many consumers have the aptitude and the ability to decipher when something is low value and high value. They're going to follow the recommendations of their providers. So when we talk about the role of purchasers, I'll just do this very quickly. We really talk about kind of a 5-point plan. The point one is understand the problem. Purchasers have to understand the problem. They have to understand why doctors overtreat and why patients might ask for things they don't need. We need purchasers to really get behind this work and make sure that their organization is part of a collective community-wide effort. And if there isn't one in your community, then you should work with other purchasers to start it, because a collective voice among purchasers is way more effective than a single purchaser. You need to demand transparency and understand not only your data, but data for your community so you can benchmark yourselves against your community and nationally. You need to teach employees to think critically about their health care. This is where the 5 questions come in. And then, as Neil mentioned, you really need to work with your insurance carriers to make sure you have strategies in place to address overuse.
Great. Those are both wonderfully nuanced answers. I really appreciate it. I am going to unmute all the lines so that people can start asking questions aloud if they'd like. I do have some questions and comments already in the chat box, so I'll start with those. We have one person who has said that Mercer is promoting incentives to employees who download the Choosing Wisely app as a comment, if either of you would like to respond to that as a tactic.
No, it's news to me, but it's great to hear.
Agreed.
And then I think we have a question for Susie specifically. What are some of the low-risk type procedures that you see having a large amount of unneeded pre-op work?
There are literally thousands of different procedure types, and I don't have them all in front of me, but let me see if I can, I'll just say that, because I don't have them in front of me here, there's a lot of eye surgery, like cataract surgery. There's urinary procedures and OBGYN procedures. There are some orthopedic procedures. So, these are low-risk procedures, and the people having them are either ASA1 or ASA2 category patients, which means that they're really pretty healthy patients overall. They don't have significant chronic disease or other issues going on. And so it's not, so when we talk about dropping the pre-op testing, we're really talking about it specifically for these patients who are otherwise healthy individuals. I was trying to find my my information sheet that's got, a lot more specifics on the procedures, but I'm not finding it right at the moment. If whoever that is contacts me, I can give it to them over email.
Great, and I can give you that person. So I'm going to take a moment and let anyone ask questions. You may have muted yourself, but you are, from an administrative standpoint, unmuted. Are there any questions for Susie or Neil?
So while we're waiting for a question, I actually found it. So the examples of low-risk procedures include arthroscopy and orthopedic procedures that only require local anesthesia, cataract, corneal replacement, and other ophthalmic procedures, cystoscopy and other minor urological procedures, dental restorations and extractions, endoscopy, hernia repair, minor laparoscopic procedures, and superficial plastic surgery.
Great, thank you. We have more in the chat box. So can you please speak to the benefits of calculating waste and taking action via a coalition versus using the Milliman calculator independently?
Well, that gets to the slides that I had towards the end of my presentation. Just calculate. The health waste calculator is a cool tool, and I like it, but the data, the results that we get from it is really just the starting point. The way that you have to really affect change in a community is to engage people using the data. So that's why we talk about translation and conversation. It's to be able to help people understand what it means, why it's important. I mean, I really liked what Neil said, which is that waste is a multi-stakeholder problem, and it's going to be a multi-stakeholder. It's got to be a multi-stakeholder solution. And the only way to really do that is to engage different stakeholder groups whether it's consumers or employers and union trusts or health plans or provider organizations, is to really engage them in a unified dialogue using the same data so that everybody's kind of operating from the same point of view, and then to try and begin to align strategies and incentives.
Yeah, I would add to that. I think that's a great answer, and I would just say, why do we have regional coalitions? It's because individual employers have limited ability to influence their local market. Even my biggest members, like Comcast or Vanguard or Lincoln Financial, they can look at their own data and say, oh, we have an overuse problem. But what do they actually do to make changes? They can change their benefit design, but to get out and talk to providers, to talk to health plans, get them to do something differently, to work together, coalitions play a pivotal role in representing the interests of their employer members.
Agreed.
Great. We have another question that asks, is there data regarding wasteful expenditures in inpatient versus outpatient treatment facilities? I'm guessing that's for you, Susie. Did you look at the difference between types of facilities?
No. In fact, that's kind of on our to-do list, if you will. Right now, we're generating results for the whole state. Our new report will show results broken out by commercial and Medicaid. But one of the things we really want to be able to do is attribute results to provider groups and report results by sort of large system, not by individual docs, but by, we have a number of large integrated delivery systems in Washington State, and which include hospitals, and they're vertically integrated, and I would like to be able to produce results by provider organizations so that we could look at results that compare, say, Kaiser Permanente to Multicare to Franciscan Health to UW Medicine, sort of at that large, kind of more at the 5,000-foot level than the 100-foot level. But I think that that's a very important next step that we're working towards. And actually the providers in our community are asking for it.
Great. Yeah, I think that'd be really interesting information to see. A few more comments. I should say there's a question about the 5 questions for each specialty. Just to answer that, our 5 questions are general questions, although there are questions specifically about antibiotics. They're just 5 questions to engage patients in conversations about overuse in general, but I will post those in the chat so that you can see them. And then we have another question. How do you deal with the inevitable anecdote that prove the value of a particular activity that's usually low value? For example, the occasional case of anemia picked up on a pre-op testing that's used as evidence of wholesale testing.
Well, one of the things that we always say when we talk about these results in our reports and whatnot is that, the results should be viewed as directionally correct rather than absolute. So this analysis gives us a place to look. So we know of the 47 things, 11 of them are things we ought to pay attention to. The exact numbers associated with the 11 things could be off, by some factor. But so that's the first thing I'd say. The second thing I'd say is we never, in quality measurement, and that includes waste, because this is a quality issue, we never expect things necessarily to be 0 or 100, right? You're never going to get rid of all of it, nor do you always expect underuse measures to achieve 100%, because there are always exceptions and anecdotes. And so I'm not really that interested in the anecdotes because they're always there, and they actually don't prove any point. except that there are exceptions, and we know that. But what we know is that there's a solid base of evidence around many of these things. For example, cervical cancer screening. How often does that need to occur? So, sure, there might be an exception, a woman here, a woman there that needs something more frequently, but the vast majority of women need it every 3 to 5 years, depending on which test you use, but they don't need it every year. So that's how I answer those questions. I think it's a distraction. I've been doing this kind of work for a long time, and I've worked in the delivery system for a long time, and I think those kinds of comments and questions are a distraction. They are a mechanism to get the conversation off of the larger topic, which is how do we reduce waste, overuse, how do we improve quality and stop hurting people?
Yeah, Susie, I agree. The only thing I would add to this is one of the things we've been thinking about is that whole defensive medicine angle. And is there some way to provide some level of protection to providers who practice in a appropriate stewardship manner to protect them from that rare case where a test might have revealed something sooner or might have been done? I don't know if you have any thoughts on that. But, you know, we're thinking about at least exploring with our some state legislators and Department of Insurance. Are there some other ways to help protect providers who have practiced in a judicious manner?
Yeah, in Washington State, some legislation was passed a number of years ago that do protect providers, give some protection against malpractice when, in certain instances, when patient decision aids have been used and the patient decision aids are certified by the state of Washington. So I agree with you. I think defensive medicine is a real issue for docs, and I think one of the ways that will help them move beyond that concern and fear is by trying to give them some cover when they are practicing clinically appropriate medicine.
Thank you both so much. With only 3 minutes left to the hour, I'm going to close up our conversation. I do want to thank both of you, thank the over 70 people who showed up to participate with your great questions. The recording of this will be posted on Workplace. If you'd like a copy of the slides, you're welcome to send me an email and I can send those out. I have posted the information that Susie provided about the report in the chat box, but we'll also be putting that on Workplace. And the information that Neil gave about the conference is in the chat, but we will also put that on Workplace. I appreciate everybody showing up today and having such a great conversation, and particularly to the two speakers. I look forward to talking to you all again next month, and thanks so much for the work you do in Choosing Wisely.
Thank you.
Thank you.